version. I'm just going to adjust that. Alright, so I'm going to do a right IJ on this guy. So at this point, I've gotten consent. I've talked to Mr. Blue Phantom. We need to have the central line and discuss risk benefits, all that stuff with him. And what I'm going to do is I have my cap on, and I'm just going to put my mask on. And then I'm going to do the pre-scan to just check for his vascular anatomy and see how everything looks. Move things into a good position for me. There. So I usually switch to the vascular or venous. And then I have my linear probe, which is the rectangular shaped one, which is the one you use for vascular structures. And then I'm going to have my indicator to my left so that it matches on the screen.
And Dr. Nomura, you add your gel to your probe, not to your patient, correct?
I tend to, yes. So it could be done either way. I tend to put it on my probe and then place my probe where I need to. Some people prefer to put a big blob on the patient. So I can see my two vessels. I can see my vein and my artery. My artery is pulsatile, my vein is not. And when I compress, my vein collapses, my artery does not. So I've identified which one is my artery and which one is my vein, so I can safely cannulate that. So at this point, I'm going to start getting things ready for the procedure. I'm going to put a little non-sterile gel here on the probe itself and get everything into a good position here. And this is the part that always happens. I'm just going to clean off the non-sterile gel so that it's easier for me to sterilize him. And at this point, Mr. Blue Phantom, we're going to do a timeout. Mr. Blue Phantom needs a right internal jugular central venous catheter. We're going to place it on the right side because that's a good side for cannulation. It's going to be a safe procedure. He's already consented. And since we're not using cautery, it's a low high-risk potential procedure. So I'm right-handed, so I tend to look from here up. So I tend to have my machine on this side and my supplies on this side. Some people may swap sides depending on what their comfort level is and where they prefer to reach for things. I prefer to be able to reach to the machine clearly and then be able to reach from either side for what I need. To the point, I'm going to go wash my hands. Then I have my kit, my PPE, and my gloves. I don't like the mask in there, so I tend to use the other one just because it fogs up my glasses. But everything you need is in there. The hat, the cap, the gown, and then you just need gloves in your kit. And start for our ultrasound probe. I tend to use my own cap because it's double for when I shave my head. People won't get stuck. So, we're now going to start opening everything up. Here we have our chlorhexidine. I'm going to open up my chlorhexidine. I'm clean, but I'm not sterile yet. I'm going to break this, and then I would do a back and forth scrubbing motion on our gentleman here to clean him up. This has a little orange dye in it. So I'm not actually going to do it so I don't stain him. And then now I have to wait 2 minutes for it to dry, according to the new labeling directions. Okay, so now while that's drying, I can do everything else. grab the corners here, and then fold towards me. Fold this away from me. Get more space here. And that gets me around here. I'm going to open this up. And the nice thing with these sheets is they have a little thing there, so I can hold that and just toss that off my field. Not contaminated. So now, I can open up my gloves. And if they dump their gloves on the field, that's wrong, they fail. And normally I will put him into November position, which means his head's down and his feet are up at a slight angle. But I'll leave him flat just for the, I think it's easier for the cameras if I leave him flat. Can you be my assistant? Thank you very much. Let me pull up first. So part of the glove and nut thing is they can't have their hands out through the white part. The first glove is almost the hardest. And then you can get all your fingers and everything situated where you need it. So that's why you have that little tab on there so you can spin and not get contaminated. So now he's had enough time to dry. I'm going to take my drape here. My drape nicely has a little mat on it, so I know which side goes towards the top, which side goes towards the bottom. Peel that off. Cut that off. Roll this towards me. Then with hold here, hand that off the middle so you can pull that down. We have a nice large area for it. Got a big wide scarlet drape. And then now I have to prep the kit, which means getting a lot of stuff out of my way. Papers, quarter package inserts. And then now that I have a sterile field, I can put my ultrasound probe into the sterile pack and bring it onto the field. Because if you do this too early, you don't really have anywhere to put the probe. So then you have a sterile probe and nowhere to put it. So I'll throw like a sock. Then you put your rubber bands on to hold the plastic in place. And then you can just lay it on your field. I tend to put that on so I can hit buttons, but that's kind of bonus. So if the residents don't do that, that's fine. There's a couple things that I do that are bonus. I'll tell you that if they're like extra stuff. That's more style points. So to prep the catheter, it comes with these end caps on. Those are just to keep things from falling in the catheter. So those are going to come off, and then the microclap ports go on, which are end caps here. They go on the blue and the white, The red stays open because that's our distal port. That's what the wire exits out of. So now, I'm going to flush my catheter. So I check all 3 ports with the caps on. Make sure that saline exits all 3. Because one thing is you have to expel all the air from the catheter. So catheters are empty of air. There we go. So the blue and the white are now have no air in it. The cap seals it. The red port will still have some air in it, but I made sure that it's flushed so I know it works. So now that I know my catheter works, I'll start prepping everything else. Because if the catheter doesn't work, then you need a new kit. So why bother doing anything else at this point? I'm going to take this end piece off so my glue cap's ready to go. Take out my little skin lock. You split that so that that's ready to go. Get that out of my way. That out of my way. And now, I'm going to open up my lidocaine. So it's a glass ampule. It's scored for it to snap. You never want to snap it with your just your glove hand, because if the glass shatters, it can cut you. But you got to make sure that you have it separate, because you don't want to use that gauze that now has potentially glass fragments in it on the patient. You also don't want to toss it in the trash because it's got sharp in it. So put it on the side. I'm going to drop some lidocaine to numb the patient using my filter straw on this little needle. Some people turn it upside down, some people leave it down. Doesn't matter. So you have to use a filter straw to make sure you don't get any glass into the syringe. And you actually have 2 syringes here. They're exactly the same. One's to do the lidocaine for your cannulation when you stick to put in the catheter, and the other is for when you do sutures after the catheter is in place. So you don't want to inject out through there, else all those glass fragments that are in the filter are going to go everywhere. So you fill one up with the little and one with the lot. You have 2 needles here, a blue one and a red one. The blue one is slightly longer, which is used to do your numbing for your catheter. And then there's a red one, which is slightly shorter and a smaller gauge, which you can use for your sutures after. So I just load the needles with the caps on. So now what I'm going to do is, that's set. I have my syringes loaded. I'm going to take a little bit of this sterile gel that came with my ultrasound probe cover. Squirt a little bit of gel on him. And then I'm going to take a look at my picture. And so I can see, oh, you don't have to pulse it. Yeah. So you can see that the vessels I identified before by depth and location, I know which one's the artery, I know which one's the vein. If I need to confirm again, I can just compress the vein, and I see it compress. So I'm good. So now, I know where my vessel is. So now, I know where to numb it. Because if you don't know where the vessel is, you're just kind of blindly numbing the person, which won't help. Which some people still do. So what I would do here is, I would take this off, and then I know where my vessel is. I'm going to raise a little skin wheel, and then I'm going to inject deeper. Pull back on the syringe to make sure there's no blood, and inject more lidocaine, inject it a little further down, or as I pull back. I tend to do it under ultrasound guidance, but not everyone does, and you don't have to. Once you localize it, you're numbing up a very large area, so you don't necessarily have to do it under ultrasound guidance. I tend to. So now, after that's done, you don't recap the needle. You either put it in your styrofoam, or this one, because it's a safety needle, if I've injected everything, when it clicks, I just pull it back and the needle's covered, so it's safe. That's why you have 2 syringes, because the other one, because once you lock it, that syringe is dead, so then you can't numb them up for sutures. And patients didn't like that, so they added a second syringe. So now that I'm numbed in, that's going to kick in for a little bit while I get everything else ready. the syringes have a little seal on them when they're manufactured. So you just have to break that seal a little bit, just a click. I tend to leave the cap on so it doesn't spray everywhere, but it doesn't matter. It's one of the extra things. So I'm going to make sure all my things are set up. I'm going to need my wire. That's just in my way. I'm going to need my non-lure lock thread, which is the one without any grooves. So this is a lure lock thread where it has a little screw to hold a needle in, versus this one which is just a piston tip. This is what you want to do your cannulation. So I have to choose my needle. These are normal size gentlemen. So my introducer needle in this kit comes in two sizes. Or it's the same needle, same type of needle, same diameter, same gauge. It's just that they're two different lengths. So for him, I'm going to use a shorter needle. So, which I would not have uncapped at this point, except just to show you. So extend that still capped. So I would just have that ready. And what you're going to do now is you just have to have things set up so that you can easily grab from one piece to the next piece. So I'm going to cannulate, I'm going to stick the vessel, get access, then I'm going to need my wire. And once my wire is in, my next step would be my dilator. And then after that, I put the catheter in. Some people will put things on the patient. I tend not to because I don't know if they're going to move or not. And so I don't want them to move and then everything fall down on the ground. And potentially I could still have a sharp in the patient and then lose the wire because they move. So I tend to leave it all on the container. Something that not everybody does, but I tend to do is these wires have a little port there so that you can just lubricate the wire before. So it's just easier to work with. Which most people don't, but I'm not sure a lot of people know that that's there. Yeah, that's just bonus. It just makes it easier for me to use the wire. Then I'm going to have my suture open and ready. My biopack I tend to leave closed so it doesn't get dirty or like wet or blood gets on it. Because at that point, everything's pretty much set, so I don't need to urgently get it. So I'd rather leave it closed so that it's stable for me. So, everything's set. I have my needle, I have my wire. I'm going to take that cap off. And now, this J point just has to be back in the pink part there. So, on the checklist it says transverse, right? Okay. Yeah, pretty sure. Okay. So there's a couple of different ways to do central venous access. There's an in-plane and out-of-plane, but we teach mostly the out-of-plane because it's easier. So for the medicine residents and the surgical residents as they're starting. So, cover comes off. I see my vessel in a transverse plane. I can see where the center of my probe is from where I'm looking. I can see the center. And I can see that the bottom of my screen is about 4 centimeters. So the center of my vessel is about 1.5 centimeters down, based on where it is. So I'm going to puncture the skin a little bit back, maybe about 1.5 centimeters back. And once I'm through the skin at about roughly a 45-degree angle, at this middle of the probe, I'm going to slide my probe back so I can see my needle. So I can see my needle on the screen now. I'm going to advance my probe caudal, and then advance my needle a little bit. Advance my probe, advance my needle, and work it down this way in a stepwise fashion so I can get my needle tip right to the wall there. And watch it go through the wall and not through the back wall. So I can see my needle tip there, and it's not through the back wall. So I pull back just to make sure my needle's patent. I have a little bit of blood flow there. Now I'm going to brace my hand down on the person, grab the needle which has a square base, and that syringe comes right off. And now I'm just going to plug that with my thumb so they don't bleed too much. My nurses don't get mad at me. And then the wire, the pink part, slides right into the pink part of the needle. That's why they're color matched. And then I'm just going to slide my wire in. Wow, somebody really filled them up this morning. Let's think of this pressure as well. So I just slowly advance my wire. At this point, I'm listening to see if there's any activity on the monitor. I don't hear it beeping at me, so I know there isn't, and no one's told me there is. So now my wire's in. I'm going to hold onto the wire and pull the needle back over the wire. And once the needle's out a little bit, I'm going to grab the wire under the needle so the needle can come off, never letting go of your wire. Now that I have my wire in place, I'm going to use my ultrasound probe again, take a look, and make sure I see my wire going into the vessel there. So I see my wire in the vessel. I don't see it through the back wall. So now I know my wire is in the correct vessel and not through the back wall. Take my syringe, make a little skin nick, and at this point, I'm going to transition to the juice box guy. I'm going to just pull my wire out here and reload it. So when we have them doing it on the big patient, sometimes I'll move the drape over, or sometimes I'll just cut a hole in the drape here. Just to get access to the juice box. And so we're going to pretend like the needle's in. I'm going to brace my hand down, pink to pink, and thread my wire in. And what you'll see is on the wire there's these bars. Each bar is 10 centimeters. So when you hit 1 bar, it's 10 centimeters, 2 bar, 3 bar. Then there's 4 bar. And this only goes for 50 centimeters, so after 4 bar, it just ends at the end. Other wires will have other markers beyond that. So needles in, wires in, needles out. So I would scan here. I can't scan because he's the juice box guy. So now that I have my wire in place, I'm going to take my 11 blade. I'm going to incise through the skin and into the soft tissue just a little bit. It's a puncture motion, not a cutting motion, because it's an 11 blade. So just put it there and I just insert it and pull it back. And I make sure I cover my sharp so I don't injure myself. And now I take my dilator. And you notice everything I'm doing, I'm always holding onto the wire. So I feed the wire through, and then I grab the wire on the other end, so that you'll always maintain control and grip on your wire. To dilate, it looks like this is the handle, but it's not. That's just the end. So what you want to do is you want to make sure that you're holding down low, so that as you advance your dilator, you're holding low here and twisting in a little clockwise or counterclockwise motion. But if you hold up here, you'll bend the dilator and it can kink the wire. And then you may have some trouble getting it out, which is always bad. And theoretically, it could bend the wire and it could potentially snap it, and then it embolizes. And that's very bad. So now, once I've dilated, and you don't have to insert it to full depth, I'm going to pull the dilator out. And what I tend to do is I tend to put a little 4x4 there, and I hold pressure while I pull this out, because now they're probably going to bleed more. It's not necessary. If they bleed a little bit, they bleed a little bit, but it's kind of messy, so I tend to hold the 4x4. Now I take my catheter, and I've left the cap on because there's a saline activated hydrophilic layer on the catheter, so if it gets wet when you flush it, it gets a little slimy, so it's easier to advance through all the soft tissue. But if you don't leave this cover on, then it doesn't soak in the fluid, which makes it easier, but that's more style points than anything else. So I'm going to hold my wire, hold the tip of my catheter, and you just got to get the end of the catheter onto the wire. So I tend to hold very much toward the tip. And then you just got to thread it on, which becomes a little harder sometimes when it's a little slimy. But so once again, I'm feeding my wire back so I can see my wire. The wire is going to exit out of the red port here. So now I can grab my wire there before I let go down there. So now I have control of my wire up here. I'm going to insert this. Once again, if you got to do a little twisting motion to get it to slide easily to your depth, he's probably an average adult male, so we'll put him to about 16 centimeters. The last number is 15. So, and then there's marks everywhere after. And then once again, the bar. So there's 2 bars here, so that's at 20. So I'm going to put him to 16, so the one line right after the 15. I'm going to pull my wire out in a straight motion and lay it on the field. Make sure they're not curling it, because if you curl it, when you let go, it unwinds and then blood splatters everywhere. And then you just got to cover the port with your thumb until you get your cap on. So now my cap is in place. I'm going to take my syringe. The red port, I use the syringe that I use to flush everything because that's the one that's emptied the most. So on your red port, you have to draw back till you pull blood into the syringe because there's air and there's some air bubbles within that catheter. So you have to draw all the air bubbles till you get blood in the syringe. And then you can flush the catheter. Huh?
There's a little thing.
Yeah, there's a little blood in there. Nice touch. And then now I would just check the other 2 ports. So here, because we have a solid column of fluid, because we have the catheters on it from when we flushed, I just draw back to make sure there's some blood in the tubing, and then I flush it clear. You just want to make sure you clear all 3 lines of any blood in there so it doesn't clot. Because there's no point doing all this and then your line clots. So now, where my catheter is, I'm going to take this sliding skin lock again. So this white part splits open, fits on the catheter, split side down towards the skin. Then now the red port goes over, and there's these 2 grooves in here that align with the grooves on the white part here. Get that sliding skin lock right in place. Now, once that's in, I kind of know where my catheter is going to sit. So now I know where I can inject some lidocaine to numb up for my 4 sutures. Because if not, you're just kind of blindly picking spots to numb, which never works out well. So now that I have that set, clean him up a little bit so he's not bloody. Bio patch. If it didn't fall on the ground, the bio patch would go on, the blue side up towards the sky, and the slit goes at either 5 o'clock or 7 o'clock. So that when you pull the tegaderm down, it pulls the catheter out. So now that that's in place, you have enough space for your bio patch. I'm going to take my needle. This is a straight needle. So when you're doing it, you're going to have to puncture the skin. That was going to be it. Make a suture there. So, you're going to have to do a hand tie. I tend to put a tie onto the skin. And then I suture the catheter to the tie that I put on the skin rather than directly to the skin. When you thread through the eye holes to suture in, you thread dull end through. You don't want to stick the sharp end through, because you got to catch it with your other hand. So you want to put the dull end through. And then this varies. You can loop through once, you can loop through twice, 3 times, whatever your preference is or how OCD you are. That goes down, and then now you tie another hand tie knot to hold the catheter down to that suture and meet in the skin. The interns will probably not suture as quickly. And then I use my scalpel to cut the suture here. Once again, sheathing the blade so it's safe. And then I would then go on to suture all 4 in place. We're generally only having them suture 1 because of the time, but I would have to suture all 4. They have to suture the 2 on the red and the 2 on the white, because they serve different purposes. The red one keeps extra catheter from sliding in and taking dirty catheter that's outside the skin and sliding in. The white one keeps the whole thing from being pulled out. So they serve different purposes. So all 4 have to be sutured in. Put that in the needle holder. And then I would go ahead and suture the other 3 in place. And at this point, I'm going to take some 4x4s, cover the area, make sure all my sharps are off the field. At this point, pull my blade down away from the person, toss it on the side, and then put my big Catheter on to just cover the area, and then finish cleaning up. And then I come back to here, and to clean up my sharps, I usually throw all my paper stuff on the side. All my sharps stay on here, and then I take the whole tray over into the sharps container and dump it all in the big sharps container, rather than picking each individual sharp out and then sticking myself. And then I clean myself up, then write my procedure note. All right. Any questions?
You didn't mention it, I know they get in training. Another issue I've seen is people getting confused on the reference point on the probe handle.
Oh, yeah.
They start out backwards and then they can never cannulate correctly.
Yes. Oh, yeah. So the indicator, let's reload this so it's not just flopping all over the place. So on the probe, there's like little markers on the side. So this marker aligns with that green dot. So this side of the probe is this side of the screen. So when you're looking at the screen, this is on my left. So that's off to that side. So you just want to make sure the indicator matches. So that when I move the probe this way, the screen moves that way or this way. Because if you actually get it inverted, then you're moving one way, or you think you're moving out this way and you're really moving the other way, and you get all discombobulated. And if you're ever unsure, the easiest way is you just touch one side of the probe and you see which side you see your finger on. So it's like, okay, that's my indicator side, so this is the side that I want on this side versus that side. Because once you get disoriented like that, then it's very easy to make a mistake, and then you're aiming immediately, you think you're going one way and you're going the other way. All hell breaks loose. People start getting carotid, stroke. Bad day for everybody. Make sense? Any questions about this kind of stuff?
The other question I had was, I guess when we were taught, we were just taught that you have to shoot the glove onto the sterile field. Is that not true? Because I know you said when you did it, you didn't have to.
Well, it depends on how you're doing it. So if you put the gloves on the field, you have to really make sure that you have your hands covered, because and it depends on what you touch. So was that with that?
Yeah.
So she's very particular about making sure her fingers don't contact the paper.
Right. But she was also using the sterile field to help the gown fit, correct?
Oh, yeah.
She wasn't using the sterile field of the sample, right?
Yeah.
Okay.
And that's the other thing, because when you open that pack, if your fingers touch that paper, you've contaminated that paper, which is the outside, so it's not a big thing. But if you then put that on your field, that part that you've touched now touches that.
Yes.
And that's bad. If you're like that and you're very fastidious about stuff, that's one thing. The residents aren't, so I don't trust them. Detail oriented and not fastidious about it.